Hello everyone, I'll be talking about our QI project, which is improving obesity outcomes in an academic clinic. Obesity is a chronic disease that affects more than 40% of the population in US, and less than one-third of the patients follow up with an obesity-specific visit. In our clinic, we found that there was a gap in comprehensive and satisfactory obesity counseling, and we hope to address this gap with this project. This is a SMART goal for a project, which is to improve obesity counseling rates and usage of the standardized obesity templates in the internal medicine outpatient clinic by 25% in 3 months. To better address this aim, we split our projects into two phases. So the first phase was improving obesity counseling rate, and the second phase was increasing the usage of obesity templates. This is the fishbone diagram for a root cause analysis. There are several reasons why there are poor obesity outcomes. This can include unclear or weak documentation. There is an existing knowledge gap, or there's lack of standardized scripts. Sometimes there's just not enough time during a patient visit to address obesity as a disease, and sometimes patients may have trouble with their insurance coverage. To better understand which interventions have the most impact, we used a project management tool called as the Impact Effort Matrix. How this works is that we plot all the different interventions in this 4x4 matrix. So anything that has a high impact but a low effort would come under this box, and these are known as quick wins. There would be some interventions which have low impact but also have a low effort. They are like fill-ins, and some interventions have a high impact but also require high effort, and these are usually big projects. So we picked three interventions from each three of these groups. We used a standardized template, we used reminders to use the template, and we also created an education curriculum. Our first PDSA cycle focused on improving obesity counseling rates. We started by incorporating an obesity management education curriculum, which was attended by all internal medicine residents. We then introduced an obesity counseling template that focuses on comprehensive and satisfactory obesity counseling. We encouraged all residents to use the standardized template in hopes to increase the obesity counseling rate. Our baseline obesity counseling was calculated at 32%, and our goal was to increase the counseling rate by 25%. This is a run chart that we use to track the obesity counseling rates during our first PDSA cycle. The orange dotted line that we see over here is a goal counseling rate, which is 40%. We also calculated a baseline obesity counseling rate looking at data 3 months prior to the intervention, and the baseline counseling rate was around 32%. So we introduced our education curriculum and the template around here, and post this intervention, we did notice an increase in the obesity counseling rates. However, as we were tracking the rates, we did notice a dip around here, and that's when we introduced a reminder to use the template. After this intervention, we did notice an improvement, and we were able to stay over our goal, which was 40%. For our second PDSA cycle, our goal was to increase obesity management by the usage of an obesity assessment and plan template. This template included all aspects of obesity management, including lifestyle modifications, exercise, pharmacological agents, and screening for disease-related comorbidities. Residents were encouraged to use this assessment and plan template, and our goal was to increase template usage by 25%. The outcome measures for PDSA 2 was template usage by residents and reduction in patients' BMI. These are some of the baseline characteristics for the patients that were included in this QI project. 58% of the patients with obesity were classified as class 1, 24% were classified as class 2, and 18% were classified as class 3. Moving on to the outcome measures, the first outcome measure was template usage. We reviewed 164 patient charts over a span of 3 months. Our goal was to increase template usage by 25%, but there was only 20.1% usage of the standardized assessment and plan. However, we noticed that in the group that used the template, there was a reduction in patients' BMI by 63.6%, and in groups that did not use the template, there was a reduction of patients' BMI by 39.4%. To understand if this reduction in BMI that we discussed was statistically significant or not, we did calculate an odds ratio. This is the 2 by 2 table that we used, and we found that in patients who had the template usage, the odds of BMI reduction was 2.34 times higher compared to patients who did not have the template usage, and the p-value for this was less than 0.05. Our next steps include improving obesity template use to meet our original goal of 25%. We'll have multidisciplinary team meetings to understand what measures can be taken to increase the template usage, and we'll be encouraging patients to have an obesity specific visit.